got a packed programme for you this afternoon. Recording has started and transmission, so that's left transcription, so that's lovely. Welcome to the 4th day of cohort 4, and we'll be taking you through a lovely series of learning sessions again. We're going to go right into it and ask for the feedback on your homework to bring forward a best practice initiative in your area of work that you feel that you want to share with everybody. So I don't know if we go with a show of hands who has something to feed back about a best practice initiative, and I'll go down the list of the show of hands, and there's something that's just popped up in the chat.
Yeah, it's Kirsty.
Kirsty's given apologies. Yes, he's under the weather. So she's going to listen. Right, that's fine, Kirsty. So for others on the call, Jane, Lisa, Sophia, Ailsa, James, do you want to put a show of hands? Put your hand up actually on the reaction if you've got something to feedback about a nice best practice initiative that you got happening in your area. So there we are, we've got Huldar. Go, thank you, Ailsa. Do you want to, we're going to give you 5 minutes to feedback so that we can keep to time. So everybody will have 5 minutes. You don't have to use the whole of the 5 minutes, but you've got 5 minutes. Carry away, go, you know, take it away.
So as I said, I work in Huldar in the South Carmarthenshire Memory Assessment Service. I'm an OT and my colleague Dawn is here as well, who's a nurse. At the moment, the service are looking at how people with dementia can be leaders in their own care and within services more, and I'm quite passionate about this, and it's my master's project at the moment, really, because I think all too often that we just assume they don't have the capacity, they don't have the cognitive ability anymore. So I think it's quite in the early stages still, from what I understand. But yeah, I don't know how much to say about it really, but I'm quite passionate about it.
How are they in? What do you mean? What are they going to do? How is it going to work?
That's what we're working out at the moment, but whether they can be involved in development meetings or whether it's how we try and involve them more in the assessment process. It's I guess the level that's appropriate for their ability. But yeah, we're in the quite early stages of it.
So is this about people with lived experience being part of the service planning and the developments of the service? Or yeah, are you saying within their own care?
Well, I think it's more about at work, it's more about, you know, being involved in the service. But in my uni project that I want to bring into work is how they can be more actively involved in their own care. So looking at leadership generally.
Okay. So having a voice then really, and sort of being feeling that they're autonomous, making their own decisions, leading what they want to happen to them when they want it to happen. It's that kind of stuff, Ailsa.
Yeah, and it's sort of reflecting, I guess, from what I haven't done big research into this, but I've worked in adult as my main job rather than adult mental health rather than people with dementia. And I feel like there's been a long way in adult mental health about lived experience leadership and having their active voice. And I think people with dementia and older adult services are a bit of a way behind. So it's really about, I think, catching up with that.
Oh, right. Interesting. Tony, you wanted to say something?
Well, I was just going to say, I'm just interested, has anybody in any other areas got any examples where people with dementia already involved in, I know, assessments or providing assessments or interviews or committees or anything like that?
Jane?
I know that I know one of our psychologists does a lot with people with dementia and taking part in sort of various groups, and I think in the past they've invited them to sit in on interviews as well.
In fact, am I right in thinking, Jane, that on your most recent interview you had a patient carer representative sitting in?
I think there was meant to be, but they cancelled at the last minute.
Oh, they cancelled. Oh, okay. That's the real practical issues actually, but just in fact, actually for the last couple of years for interviews, any interview, in fact, actually for medics, nurses, care assistants, we've actually had sometimes a patient, usually it has to be said a carer, because it is difficult to actually find a patient who can, in a way, cope and doesn't either dominate or not pick up the cues correctly. It's a bit difficult with patients in some situations, but certainly active carers of wives or husbands of people with dementia on interviews, and it's always worked very well, because it's a bit like say having medical students on interviews. The medical students always ask difficult questions, and it's the same with the patients or the carers. Having said that, I don't know the last year or two, but about 3 years ago, we did suddenly strike a bit of a problem with human resources, who started getting concerned about whether the people are adequately trained and confidentiality, and dare I say, it started being a little bit obstructive. So it's not always quite as easy as it seems. But yeah, definitely. Last time, in fact, I suppose Nigel Speaker is a very good example. Nigel is, involved with umpteen things, both internationally, nationally, locally.
Yeah, that Lifeside Dementia are a good pot to sort of source your people from that you want to be involved. I mean, in this day and age, that even with service planning, so if there's memory assessment, redesign, working on it, nothing should be happening in any forum of changing any kind of service, whether it's MAS or whether it's mental health or whether it's anyone, should be happening without people with lived experience. So I'd be really interested, Ailsa, how this sort of project gets going down with down in Hywel Dda. And so it's ongoing now. Is there sort of a timeline for it, or is it sort of early days?
I think it's early days. It's more at a management level than myself, because I'm doing my masters. I've had like odd bits jumping in and out of it, but yeah, I think it's quite early days.
Lovely. And you're able to sort of direct that and be part of it because of your master's work, are you?
Yeah, I think it's because I said to my line manager, who's the Band 8 sort of service lead, what I want to do for a project, and she was like, well, actually, we've already started that as a service. So while I don't have the time or the resources to really get as involved as her, I'm gonna do what I can to sort of link in with it.
Yeah. Oh, lovely. Thank you. That's
thank you.
really good. So anybody else pop their hand up, have a think about any questions as well for Ailsa as we go through the afternoon. You might want to ask them of Ailsa and that project, or some views about it. Anybody else had a thought about what they're doing in their own service that you think is a good initiative, a really good piece of work, and you want to share it? Or, as Ailsa has brought forward, they're at the early days of some thinking about things. That may be what you want to bring as well. Pop your hand up if you know of any and you want to tell anyone about them. That was the homework. Any other hands?
If you don't pop your hand up, you'll be
picked on
for you.
Okay, who have we got here then? We've got
I don't know. I don't putting James and Jane on the spot. What new things have happened in the last year or two in Cardiff? Don't say nothing, because that reflects.
No, not nothing. But I'm just trying to. There's lots of changes happening. It's trying to know what's happened this year. I suppose we've had a lot more doctors coming to help out and do clinics. That's been quite different.
Where are the doctors coming from? What's their background?
They're friends of Dr. Mohammed's and Dr. Schutz. No, I think some of them are coming from the wards, some of them are GP practices with an interest. But yeah, mostly doctors with a specialist interest.
So are they coming to learn, Jane?
Yeah, they do. They some come for a short period, some stay for a lot longer. I mean, I don't know how long James is staying with us, but I do know he started his own clinics last week.
James, can I ask you? Actually, it's a rather pointed question, but you're the first specialist registrar who's done this course. Can I ask you why you thought it was worth your time?
Well, I obviously met Dr. Shute more from a ward point of view, and then sort of said I think it would be really useful for my training to get a bit more out of understanding dementias and diagnoses and things like that. It's obviously part of our curriculum. I haven't taken it to sort of older person's mental health, but that's one of my things to do before I rotate in February. And then just looking at the sort of setup of the course structure, obviously doing geriatrics, I'm very keen on. I can turn my camera on. Sorry, I'm here in real life. I think the importance of multidisciplinary working is really important, and I thought this would be a good opportunity to get an insight into what other people in other services do. But also, for me, it's a lot about building my knowledge, because obviously it's a little bit lower than some people who have been in services for a long time. So there's a lot of points for me to sort of learn and build my own knowledge. I think, yeah, I'm surprised that there haven't been more registrars of my sort of caliber coming on just from an interest point of view. I know it's 4th cohort, but it's something that I would definitely recommend to my colleagues. And I think working within or doing clinics, as Jane said, doing my own clinics within the memory service, obviously it just gives me that extra bit of confidence. So like this week, for example, I was doing a little bit more independent work, and I actually had to deliver some diagnoses of dementia. So it was building some of the skills that we've talked about here and those experiences, as well as what I've observed, to do that independently, which is always a bit of a plunge, because you have the discussion, then you think, oh, do I do this bit now, or give me 2 minutes, I'll go and hover, like being a medical student, hover outside the boss's door and I'll be back in a few minutes, and then it's 45 minutes because they're all in. Anyway, we all know what it's like. So yeah, in the end I just sort of got on with it because they were fairly clear cut, but it's I think I found it interesting using some of those soft skills as well. And what we were talking about the other week was, I haven't sat in with some of the other specialty doctors yet, but it'd be quite interesting to see things from their point of view. And also, I know I've said to Jane about going out with her. I've been on call, so sod's law, I never get time. But it'd be quite interesting to see. Obviously, you get a different perspective, seeing people in their own homes, to assess those things.
Yeah, I think to me, over the years and now, and so the problem is that there's back in the past, nobody was really interested in dementia. Then people realised how common it was, and interest has actually grown. But unfortunately, it's not terribly well. It's not terribly well taught anywhere. It's not taught that well, as far as medics concerned, at medical student level, and then in training up until now, it's never actually been a large part. Certainly within psychiatry training, it's not a large part unless you actually specifically go into all-day psychiatry. And I think the same, as I understand, is for nursing in a way, is it's just a bit pot luck whether you happen to where you get a placement. I don't know, is that true, Jane? Or
yeah, that's where I was just going to add on to that. Is obviously I think I'm one of the only general nurse, well, not now, but I think Cardiff and the Vale are the only memory team that has general nurses. In the rest of Wales and UK, England, you've got to be a mental health nurse, which really frustrates me, because the amount of patients that
have to-
we come across on the general ward.
It's just, that's just the way it's been done in the past, and everybody gets a bit possessive. And I think the glib phrase is, dementia is everybody's business, and those all of us are working in dementia. I guess we'd agree with that. It's actually widening that interest and responsibility and knowledge across the board. So I don't know, maybe you can spread the word, James, and I'd encourage everybody to actually use the opportunities to actually invite sort of colleagues, whether they be OTs, nurses, whatever, to come and spend time with you. It breaks up the sort of routine of working, so it creates more interest for everybody in that way, and it just raises the general sort of knowledge. Okay, so that's I know Swansea. Right, Lisa, I can see you. Anything happening in Swansea? Your mic's not on.
Sorry.
Great.
Sorry. So, but we work quite differently. We
You've frozen for me. I don't know if that's just for me or if it's for everybody.
Sorry?
You froze for a minute.
You froze for a minute. We couldn't hear you. So,
I'm
so
sorry.
any nice initiatives coming from Swansea that you want to let us know about? Thank you, Lisa.
That's okay. At the moment, I'm in transition. I've actually moving from one health board to another. But I know there's been a lot of it sort of meetings to maybe establish a memory assessment service, MAS, within our locality, Port Talbot locality. And I know those are ongoing. And that's basically it. We as CPNs, we sort of work primary and secondary care, and we actually undertake cognitive assessments ourselves, and arrange walk-in clinics with the psychiatrist to actually diagnose. We have an advanced nurse practitioner who's been successful in post. She's based in Tonna at the moment. So there's lots of things in the pipeline that I have been made aware of, but nothing as concrete as yet. And this is my last week within Swansea Bay University Health Board after 22 years within older person services. So yes, I'm just trying to find out about initiatives in Hywel Dda at the moment. So yeah, and being a bit busy, so I haven't really sort of knuckled down to have a look as yet, but
no worries. I just wanted to ask you one thing, and all the best. If we don't say that by the end of the day, all the best in your new venture in Hywel Dda.
Thank you.
Yes, it's a big leap, isn't it? Moving from one health board after a long time to another. So yeah, I wish you all the luck. Yeah. You talked about walk-in clinics. So does that mean people can just walk in and say, "Help me"? Or
no, sorry.
Right.
They're actually they're appointed by the CPN. So via the GP, whatever it is,
I think Lisa's having problems there, isn't she? Lisa, I think you're having a few problems. So you were saying that the CPN refers people in?
Yes, we have about 4 or 5.
No, it's not coming. No worries, Lisa. I'll tell you what you could do for us.
Sorry.
And I know Tony wants to get started with the next session. If you could pop it in the chat, that would be lovely. And we'll come to a couple of people later on in the session as well and ask for So you've got time to think, as well as some nice initiatives that are happening across or within your MAS service. And that could be, you know, you've decided you're going to do something in a different way, or that you've got sort of an initiative that's happening that's being scoped, anything really. Pop it into the chat for us, and we've got that then as a log to say that you've all sort of contributed to some good innovation areas in your own teams, and then we can sort of have a look at them. We can all have a chat about them later. So if you could tell us about the walk-in clinics and how that sort of works, pop it into the chat for us, Lisa. That'd be great.
No problem.
Thank you. All right then, so for the others that haven't had a go, put some of your things you want to tell us about into the chat, and we'll pick them up later, because we've got our first speaker, I think, presenting now, waiting in the wings. All right, Tony?
Yep, brilliant. Thank you very much. So, yeah, in fact, our first speaker has just emerged from the wings onto my screen, Dr. Mohammed. In fact, we're pleased to see Bijou, because I think, when did you get back from India? Yesterday or early this morning?
Early this morning. Early
this morning. So you can see he's how important the dementia faculty is to him, because he agreed that the first thing he'd do when he got off the plane was warm up and then talk about Lewy body diseases. Now, Dr. Mohammed is he's consultant geriatrician in Cardiff and clinical director, and he is responsible for the Parkinson's service with Dr. Thomas in Cardiff, and he's also responsible for the memory clinic service in Cardiff, along with Dr. Jerry Shute. So he's going to talk about Lewy body disease, which covers, in a way, bridges between Parkinson's and dementia. And I'm sure Bijou is going to touch upon it, but actually is one of those conditions which is underdiagnosed, significantly underdiagnosed. So, okay, over to you, Bijou. Are you going to share your slides, Bijou?
I am. Yes.
You're fine. Over to you.
Thank you very much, Tony. Just going to share. I'm hoping. So I'm just going to stop sharing. I'm just going to get the right presentation up first.
Yeah.
Always helps.
It should be somewhere.
It's here. And so I think that's, can you see my screen now?
Yes. Lewy body dementia, Bijou Mohammed. That's the right one.
Yeah,
yep.
That's the right one. Yeah. Okay. Thanks very much, Tony. As always, it's a pleasure to present at this, and I think, as Tony mentioned, I think this is something that's very dear to my heart, and obviously getting an opportunity to speak to many colleagues across Wales is a very rare opportunity. So you never say no. But more importantly, I think it's the absolute respect and fear for Tony that makes me get off a plane and speak. So I'll put all of that in together. So if I'm a little bit slow or I've missed a few things, I've got an appropriate excuse for that. But I'm hoping I've rewritten the talk slightly, mainly to focus on Lewy body dementia, touch a little bit on Parkinson's disease, and I've put a few videos in here only because of the association there is with Parkinson's disease dementia. So without much delay, I'll just go on to the first slide. So the first thing to mention is that Lewy body dementia is an umbrella term which includes dementia with Lewy bodies and Parkinson's disease dementia. I'm going to go through a little bit of the difference between the two over the next few slides. I'm also going to try and go through some of the common physical signs, because I think among the dementias that we have and that we see, it's one of the rarer dementias, but it's also one that has a huge emphasis on physical signs. because of its association with Parkinson's dementia. I mean, during my clinical week, I pick up at least 1 or 2 people with Lewy body dementias, and often it's the most challenging ones. And over the next few slides, I'll explain why that's the case. If anyone's got any questions, please feel free to shout out, because I'm not sure if I can see your hands in the window that I'm on. So as we said, dementia with Lewy bodies, it's the second most common dementia after Alzheimer's, and it's challenging to diagnose due to probably a lack of awareness among professionals, and also lack of awareness among the public as well, because often, a lot of the time, when people present with dementia and go on towards a diagnosis of dementia, is often their loved ones, their family members that first raise this as a prospect. They go present to the GPs most commonly, and then GPs often send us that referral. I think this person's got dementia. A lot of the dementia with Lewy bodies go across to the Parkinson's clinic that we run, and some of them come across to a memory clinic when GP colleagues are very switched on, mainly because the first presentation is one of visual hallucinations, along with some cognitive problems. Parkinsonism plays a huge role. They present with the features that we see in Parkinson's, like tremor, stiffness, rigidity, etc. Cognitive fluctuations are a very characteristic feature here, along with autonomic symptoms, and I'll come back to that in a few slides' time. The other thing that we often see is problems with sleep, either in the form of fractured sleep, but more commonly with something called REM sleep disorder. So they tend to be very active in their sleep, shout out, fling their arms. And the final point is neuroleptic sensitivity, which is a common feature here. So they may be very sensitive to first generation neurotropic drugs like haloperidol, for example. And one of the key factors that you've got to think about is, why is it so important to make a diagnosis or get the diagnosis right with dementia with Lewy bodies? It's because there are quite a few differences between Alzheimer's and Lewy body dementia, and the way we manage this condition is also different. Neuroleptic sensitivity being one of them, but also the rate of decline that we may see with Lewy body dementia. As we said, with dementia with Lewy bodies, one of the issues that we find is that the prognosis is bleaker than Parkinson's dementia, and often it may be in the range of 6 to 8 years. And there's an increasing consensus that dementia with Lewy bodies is a clinically distinct disorder compared to PD dementia. In Parkinson's dementia, we do get a significant proportion of patients declining, but they do so over a larger period, and the progression is not as rapid as we would see with DLB. And often the dementia presents for the first time about 10 years after the onset of Parkinson's symptoms with Parkinson's dementia. So in terms of neuropathology, there is a commonality there in terms of the eosinophilic inclusion bodies called Lewy bodies, and you can see that in the picture there. This is common to both Parkinson's disease, idiopathic PD, or even in a condition called multisystem atrophy. And the alpha-synuclein, the presence of these abnormal breakdown proteins, is what causes the damage within the brain. And it's sort of in the deep cortical layers. And what we would tend to see is, in terms of the postulation of theory, is one of the theories is called a dual hit hypothesis. So Brack and colleagues many years ago, nearly 100 years ago, came up with the dual hit hypothesis, which suggested that the pathology with Parkinson's presents in 2 different entities. So they may be by ingestion of a neurotropic virus, either through the nasal system or through the gut, and then this presents and the virus then propagates up to the brain, causing the damage. We don't really have a good explanation of why cell death happens and why the progression of dementia happens, but there's ongoing studies regarding to that. So we have got much clearer criteria now with regard to diagnosing, making a diagnosis of DLB. So McKeith and colleagues, I think there's a 2nd or 3rd revision of or it could even be the 4th revision of the DLB criteria. So we make a diagnosis of DLB either probable or possible. And if you look at a possible, you need one core clinical feature with no biomarker evidence, or one or more biomarkers with no core features. And what do we mean by the core features? These are the core clinical features. So you have a fluctuant cognition with variations in alertness and attention. Visual hallucinations, as we said, is very, very classic feature of Lewy body disease. REM sleep disorder we mentioned very briefly earlier on. So it's a rapid eye movement sleep disorder. What happens in rapid eye movement disorder is normally it's the phase of sleep, the fourth or fifth stage of sleep, where the person's body is completely paralyzed, and it's a dream phase of sleep. And because the body is paralyzed, you shouldn't be moving your arms or legs. But in this case, because there is a defect in the mechanism, you see quite vivid movement of the arms and legs of the patient, often causing injury. So that's called a REM sleep disorder. And this can be a prodromal feature of DLB, sometimes presenting 6 to 20 years before the DLB presents. And you have features of Parkinsonism, which again, I've got some slides on. We talked a little bit about biomarkers there. So reduced dopamine uptake in the basal ganglia, which is shown by a SPECT or a PET scan. Often what we use is a DAT scan. And over there, you can see a reduction in the dopamine uptake by having 2 full stop signs instead of a comma sign. We've got an image of that. There are a couple of other investigations which we'll talk about as well. So just going back to the criteria. So if you have a probable DLB, you get 2 or more clinical features. So for example, if somebody's got a deteriorating cognition with visual hallucinations, that would form 2 core features. And again, then in this case, you don't really need to have a biomarker. Or if you have somebody present with a fluctuating cognition, they get a DAT scan done, that would also make it a probable DLB. Once you know the criteria, it's quite easy to make a diagnosis. But like most things in medicine, it's often a question of pattern recognition. And you know, I get referrals, and often the question is, has this person got Alzheimer's, or has this person got Parkinson's disease? I read the referral and I think actually this could be a Lewy body. And the same thing happens in the acute medical admissions as well. We get quite a few referrals with query dementia or query Parkinson's, which turn out to be Lewy body disease. So just progressing then on, we've gone through this slide. So visual hallucinations is something that's very, very prominent in dementia with Lewy bodies. And this is something that's worth spending a little bit of time to understand, because compared to other dementias, this is one of what I would say the key pathognomic features that you would see when it comes to making a diagnosis. The patients give you very characteristic descriptions. They're very vivid. They're very full when they describe to you. So for example, a lot of the times the description we get are of seeing people in the house that are not there, or little children. And the description is very, very vivid. You know, they often describe what clothes they were wearing or what they were doing. Sometimes the description is of animals, you know, of a cat or a dog that's there. This is about 3 weeks ago, somebody said, you know, there was somebody at the door. So the husband and the wife. The husband had Lewy body dementia, and they went to attend. And then after the person had gone, the husband asked the wife, "Why didn't you offer anything to the little girl who was there, who was holding a basket and had a little, you know, hat on?" And the wife was like, "What child? There was no child there." So. And the husband was quite convinced that there was somebody there. So they give you very, very florid description of the hallucinations as well. Sometimes the reactions to this vary from fear. They sometimes patient gets very scared with these hallucinations. Sometimes they recognize there is insight, where at other times there is a lack of insight. And in some cases, patients very openly tell you they actually enjoy having that conversation. But the characteristic response when you ask them, do they speak back to you? Do you hear anything? The characteristic response that you get is that they don't speak back, but they do sort of feel that they're being acknowledged. So some people actually enjoy that interaction. It's obviously very worrying for spouses or carers, and it can be quite scary till you explain why it's happening and what the cause for that is. as we said, it's very, very common. About 80%, 70 to 80% have visual hallucinations, whereas it's very rare for this to be present in Alzheimer's disease. So I think that's quite a characteristic feature. So if you ever hear of somebody with visual hallucinations and cognitive impairment or memory problems, it's worth thinking whether this might be sort of, a DLB. One of the time that you shouldn't be caught out is with posterior cortical atrophy, which is a type of Alzheimer's where you do get visual problems, but they present in people who are younger, and often they tell you they have difficulty reading between lines, or the lines keep skipping. Some of the history they give you is that they're reversing the car and they often hit into something else, and there's a lot of visual misperception along with cognitive problems, and they present more in the Alzheimer's mode than the features that I'm going to present, including Parkinson's, which is rare in that condition. As we mentioned, well-formed images of people or animals, colors, shapes, etc. There is a condition called passage hallucinations where they see that from the corner of the eye, they've seen somebody in passing, or there is a presence in the room. So that's quite commonly described as well. As we said, they can be complex in terms of conversation with deceased relatives. They can also in the later stages present with something like Capgras syndrome. So that's slightly not technically a visual hallucination, but it's also called the imposter syndrome. They feel that their spouse has been replaced by someone else, and hence they get quite agitated when the spouse is trying to calm them down or say something to them. They feel that it's somebody else who's gotten into their house and who's trying to impact on them. And that can lead to quite difficult aggressive posturing, etc. And that can be quite difficult to deal with. And often in advanced stages of either Parkinson's dementia or in terms of Lewy body dementia, that can be quite challenging to deal with. Visual misperceptions and illusions are common. So again, judgments of space, distance, seeing a curtain with waves on it and seeing a snake there, or floral patterns can turn into something else. So they can be quite difficult for people with Lewy body dementia. Executive dysfunction is something that you'd find from a cognitive point of view. Attention and concentration is something that they would struggle with. Planning and executive dysfunction is something else that's very common. So as we said, one of the problems that we have is that this is very much underreported, and sometimes you have to ask the history and it all unravels. Families and relatives, again, may often underreport this. One other place that we may get caught out is in Charles Bonnet syndrome, which is a problem where you have somebody with cataracts or other problems relating to the eye, and they have visual misperception. So they may, especially in darker light or towards the evenings, have these hallucinations, but they're very particularly related to misperception of items due to the low light and due to their visual impairments, which is slightly different. But I've had a couple of patients who've been misdiagnosed with Lewy body dementia, whereas they had a local optical problem. We mentioned that apart from the visual perception problems, Parkinsonian symptoms are very common. And it's worth just spending a few moments on what sort of Parkinson's symptoms they may get. They may present with stiffness or slowness, which is called as bradykinesia. Rest tremor is less common than you would get in Parkinson's disease, but can be seen in some patients. It can be asymmetrical, and gait disorders are again very common due to the Parkinsonian symptoms. I think this is better described with some of the videos that we've got. So the first one is just looking at a lady's gait. She's got very early Parkinsonian symptoms. You can see that her right arm is quite tucked into her body with a slight degree of flexion. She takes smaller steps, and there's a reduced swing in her left arm. So somebody with Lewy body dementia can present with a Parkinsonian gait. They can present with similar Parkinsonism and gait problems. Sometimes it can be symmetrical as well. You can get slowness. One of the ways that we examine slowness is by looking at finger taps. You ask them to repeatedly do finger taps like she's doing, or fist clenches, or tapping their feet recurrently on the ground. And you can see that there is slowness there when she does that. And when she does that with the other hand, it's much quicker. Unfortunately, I think I've forgotten to attach the second video of this, but that's definitely slower. She doesn't open her hand as fully as she should. And she's this reducing amplitude as with time. So moving on to the next slide. One of the other problems that you can get, one of the other conditions where you can get a gait problem is with normal pressure hydrocephalus. This is just to show the different types of gait problems. You can see this is much different. This is a wide base gait. The arm swing is not too bad. This is a condition where somebody has got increased fluid in the brain, the swelling on the brain that presents with pressure across. And this is an abnormal gait pattern that you get there. You can have an operation wherein the pressure on the brain is reduced. You can see there's a remarkable improvement in gait. So this is very different to the Parkinsonian gait we saw in the first instance. I've got one more gait video. This is again showing Parkinsonism, but this is a condition called corticobasal degeneration. Again, this is just to show. Now here the arm is in a much more flexed position, and you can see she's got a slightly wide base gait. She's not able to move her neck significantly. She's not able to stop either. And so that's again a different gait to what you would see with a classic Lewy body dementia. And this is the eye signs and some of the difficulties people may have with using their arms. Again, this is not seen in Lewy body dementia, but so you can see that they struggle. And okay. So right, so I'll move on to the next slide. So we've talked a little bit about some of the cognitive problems people with Lewy body dementias would get, followed by visual hallucinations, perceptive problems, and gait problems. The next slide is going to concentrate on REM sleep disorder. I mentioned this briefly in the first slide. Just to understand this, we go through multiple stages of a sleep cycle in a night. So in a typical night, you'd go through 4 or 5 stages of the sleep cycle. The first 4 stages are called non-REM sleep disorder, so non-rapid eye movement sleep disorder. So this stage 1, for example, you start feeling drowsy, you want to go to sleep. Stage 2 is you start dozing off. Stage 3 is you go into a deep sleep. And 3 and 4 are quite similar. And stage 4, you're proceeding into the REM sleep, whereas your dream phase. And what happens in Lewy body disease and some of the other degenerative neurological conditions is you have an abnormality of your REM sleep disorder, your rapid eye movement. So you have complete paralysis during this REM phase, and that is lost when you have a REM sleep disorder. So you get a sleep disorder characterized by dream enactment. And it's worth asking very specifically about that, because this is present in up to 90% of patients with Lewy body diseases, and it can result in injury. So we often pick up 2 or 3 patients every week with REM sleep disorder, and often it's the bed partner that will volunteer that information about shouting out in their sleep, acting out their dreams. So I had the chap who would shout out in Arabic, and he was a Welshman, but he was serving in Palestine in his younger days with the army, and he would shout out and he would make these actions as if he's attacking someone in order to protect himself whilst he was being attacked on the beat in his sleep. So some very florid, somebody else who used to love playing rugby and was a rugby player in his younger days, has sustained multiple injuries when he had the REM sleep disorder and barged into a wall, fallen off his bed, smashed his arm on the side table, etc. This can present, like I said, between 6 to 20 years before the presentation with memory problems or Parkinsonian symptoms. So again, it's worth asking. Some of the other features that you would say, we talked a little bit about sensitivity to antipsychotic agents. This is particularly more so with Lewy body diseases than any other neurodegenerative condition, between 30 to 50%. Worse with drugs like haloperidol, which are the first line drugs, and it is not dose related. And it can worsen mortality, increases mortality, because people can have any problem varying from just slight drowsiness to severe stiffness and rigidity to a full-blown neuroleptic malignant syndrome, which involves severe, once they've had a drug, they can get a blockade of the dopamine receptors and they have severe temperatures and stiffness, rigidity, and often needing intensive care support. So it's worth just thinking about it. And this is one of the reasons why we emphasize about getting the diagnosis right, because only if you know that somebody has got Lewy body disease, you would think that there would be a problem with this. In general, our practice now is to avoid antipsychotic drugs for people with dementia or for older people in general as much as possible. And we'd always recommend discussion with our psychiatry colleagues before we do that. And if at all we use antipsychotic drugs, we try and keep it for the lowest amount of period that we can give it for. Autonomic dysfunction again is common. Up to 60% of the patients. This may involve excessive sweating, problems with continence, postural instability, blood pressure drops, etc. Again, this is a common feature in late stage Parkinson's. You can have this in one of the other conditions called multisystem atrophy. Again, you can have autonomic dysfunction. Sleep and impaired consciousness is a huge problem in Lewy body dementia. Often patients present with features that may even be suggestive of non-epileptic seizures. So they say that their loved one just stares into the ceiling or stares across the room, completely unresponsive, and this can happen for minutes at a time. And some days they can have episodes of sleep that can go on for hours and hours, and they may have in the advanced stages reversal of the day-night sleep cycle as well. So sleep disorders are extremely common, and it's important to be aware of that. And there's at least a few cases that I can think of where people were investigated extensively for epilepsy, whereas if we take a good history and understand what the diagnosis is, then we could have spared people off those investigations. We mentioned about postural instability, and blood pressure drop is a big problem. So it's worth reviewing the medications, especially anti-hypertension drugs, to try and see if there's any drugs that can be taken off. Smell problems are common. So hyposmia is an interesting one. So that's lack of smell or reduced perception to smell, and it's a common feature in Parkinson's disease as well, because it's felt that some of the pathology starts in the olfactory bulb, which is the smell center. So there are special smell tests that can be used in both Parkinson's, although in Lewy body disease it isn't a diagnostic feature as yet. We mentioned briefly about DAT scans. So what happens here is you inject a ligand, it's absorbed into the bloodstream, and it goes and lights up the dopamine-rich areas of the brain. So over here is somebody with Lewy body dementia, and you can see the DAT scan has full stop sign, whereas here it's a comma. So that's a caudate and the putamen nuclei, and that's a normal one. Whereas over here you have the loss of the tail here. But this is only specific if you ask the right question. So this can be positive in Parkinson's disease, any of the atypical Parkinsonian syndromes, MSA, PSP, etc. If you look at imaging, MRIs, you have in the brain of somebody with Lewy body dementia, which is the one here, you have increased loss of cortical thickening, so that's quite important as well to note. Other tests are polysomnography. This would look at the sleep disorders that we mentioned about. An MIGB scan, again, this is a ligand scan that can be used to look at the innervation of the heart muscle and autonomic symptoms you get with that. It's not very commonly used. MRI scans can be useful to rule out other aspects as well. PET scans, you get a loss of occipital activity on the PET scans compared to other areas of the brain compared to Alzheimer's. A DAT scan is what we just mentioned. There are some investigational biomarkers. Some of them are sort of looking for biopsy from the skin, and you get alpha-synuclein deposits in the skin from biopsies in the gut, etc. But these are still experimental, and EEG can be useful in some cases as well. I'm just mindful of time, so I'm skipping through so I can leave a few minutes for questions. I've just put a couple of slides on Parkinson's disease dementia. Now, one of the questions that always comes is when is it PDD and when is it DLB? And there's an arbitrary 1-year rule that's cut off. So if somebody presents with dementia, with cognitive symptoms, along with Parkinsonian symptoms, then you would say this is a DLB. Whereas if they present with Parkinsonian symptoms, so tremor, rigidity, bradykinesia, and then they present with dementia 10 years later, and they present with visual hallucinations, all these features that we described, then we would call it PD dementia. So often this arbitrary cutoff is in the 12 months. So initial cognitive presentation with Parkinsonian symptoms would go towards a DLB, whereas if you've got Parkinson's symptoms and then present with the memory problems later, that would go for Parkinson's disease dementia. The overall management remains the same. One of the key features take homes from this slide is that dementia is very common in Parkinson's disease. About up to 80% of patients after about 10 years would have a degree of cognitive problems and dementia in a cohort of PD patients that you treat. Just a few features of similar to attention executive dysfunction that we mentioned with DLB. Visuospatial is again very common, again the same as DLB. And behavioral features is mood, visual hallucination. So you can see the amount of overlap that you have along with rapid eye movement. Often very early to pick up by a bedside or in clinic. There's an old feature of a mocker and the clock test that you'd get there, and you can see the clock test is very easy to pick up some of the visuospatial problems that you have. It's quite useful to remember what are the differences in neuropsychological profile when you're dealing with Parkinson's disease dementia or Lewy body dementia versus Alzheimer's. And memory problems are sort of less prominent. It's usually the attention, the fluctuation and the concentration ability, the executive dysfunction that's much more common in PD dementia. Memory problems come on as a significant issue later on. It's generally a retrieval problem rather than a registration problem. So you try and, the ability to recall, it just takes time for them to get that. Visuospatial problems, as we showed on that clock test, is very common. And the psychotic features, visual hallucinations, are much more prominent in Lewy body Parkinson's sort of prodrome compared to Alzheimer's. And in very late stage Alzheimer's disease, you can get extrapyramidal features. And some of the referrals that we get often are, this person's had Alzheimer's for 7 or 8 years. Do they now have PD dementia? And the answer is generally no. I won't focus too much on this, but effectively, it's what we said earlier. If you've got a diagnosis of Parkinson's disease and then they're developing a cognitive syndrome, then the likelihood of it being PD dementia is very high. So I think that's pretty much the main features that we have suggested. And the spectrum of cognitive failure in Parkinson's disease, you can have an MCI feature as we would. So they have cognitive problems, but the activities of daily living are not impaired. They're still functioning independently. Then you can get the DLB, PDD, and then you can have a mixed dementia as well. And it's worth remembering that DLB and Alzheimer's can coexist. So even if they have visual hallucinations, but they have predominant features of Alzheimer's as well, then it could be a mixed dementia. And we do see a few cases of that every year as well. So I think I've rushed through, so I've left a few minutes for discussion. My sort of top tips if you're dealing with a case of Lewy body dementia is the story is central. As with most dementias, it is making sure that you take a very detailed history, focusing on some of those features we described. Look out for those features of Parkinsonism, and they would then tip the diagnosis towards that of a Lewy body disease. The neurocognitive profile, as we mentioned, and sometimes if the story isn't clear, often I shy away from giving a diagnosis, and often time is the best diagnostician then. And always remember that if the story, the neurocognitive assessment, and the signs that you're seeing don't fit, ask the question why, because there might be another diagnosis there. I think that's my last slide, and I've hopefully a few minutes to take some questions.
Great, thank you. Thank you very much, Bijou. Any questions or points of clarification or anything anybody wants to bring up? James.
Hi, Bijou. I just quickly wanted to ask, obviously, you mentioned that sort of the visual hallucinations, REM, are very, very common. Would you say that the Parkinsonism features are cardinal? I know it doesn't fit into the diagnostic criteria as an essential, but do you find that they do tend to have some degree of Parkinsonism alongside?
Not all of them, and like I think that in that sense the diagnostic features are useful, because Parkinsonism again is common, but it is one of the core clinical features, but it's not necessary that all of them have to have. What we tend to find is, or the key features that raise the suspicion, is that cognitive impairment along with those initial features of visual hallucinations plus a degree of Parkinsonism. So sometimes you don't get the whole house, but Parkinsonism is fairly common. I would say about 70–80% of the patients would have a degree of Parkinsonism. Often the problem that we find is the other way around. They're often diagnosed as idiopathic PD. And then, or the question, it comes in as this: we think this person has got Parkinson's. What do you think? Because that's much more common out there, isn't it? People recognize stiffness, tremor, and slowness, and they recognize features of Parkinson's disease. So often we have the other issue is that we're often unraveling a diagnosis of Parkinson's disease to tell them that although this has some of the features of Parkinson's, you've got a cognitive syndrome because of A, B, and C. And also the other thing you find is that it is often misdiagnosed, and you find that you have to wait for a couple of years. Sometimes those features of visual hallucinations are often, and I haven't mentioned this here, which I should have today, is in hospital. Often we get caught out with a lot of patients with delirium who are diagnosed the other way around. They get that diagnosis of Lewy body dementia from hospital, and there's one or two cases a year that I would then have to say, look, actually, although you had all of these features, we don't think you have Lewy body dementia, because they've got better, and we follow them up over time. So I think it's very, very important. And as part of this talk, I think I should add that slide in about the importance of thinking about delirium, especially in the acute phase. It's less common for people who are not doing hospital practice and doing predominantly a community practice. But in the hospital, that's a common issue.
I was partly out of, one of the patients I had this week was clearly cognitive impairment, but actually talking to the person who was helping to look after them, had quite striking visual hallucinations and REM sleep disturbance. Yeah. I didn't dig into an awful lot of the Parkinsonism features, which is probably more operator error. She wasn't obviously Parkinsonian, but things like the clock. And then so we were discussing sort of ultimate formulation, and then, like say, the delirium. I was on call this weekend and had a chat with known PD, but just out of interest, really good description of visual hallucinations, which I don't know if he's still in. I'll point the medical students towards, but it was like classic delirium with Parkinsonism, just very clear hallucinations. He had fantastic insight into it, but very classic.
Yeah. And I think that's one of the things I focus on when I do the medical student talks. Is almost when I'm asked to do a talk on dementia, I spend almost half the time on delirium, because of that sort of misdiagnosis that can happen, and also the opportunity to intervene in the acute setting.
Yeah, and I think sometimes it's as much the reassurance for the next of kin and relatives, because they think they're not going to get back. But sometimes they don't. But it's
sure.
Yeah. Thanks.
Thanks.
Great. Thanks very much. If there was one parting message, Bijou, what would your parting message be?
I think my parting message is a detailed history. I think that's the key. That's the key, and a detailed collateral history in particular. And again, this is focusing on the Lewy body dementias. Is often the partner or the carer is the best person in terms of getting that collateral history from, because often the patient does not recognize some of those features, or the patient has lived with the condition for so long they assume some of them. I mean, I had a patient who turned up to clinic and thought that it was normal to see these things, and it's only in taking the collateral history that you recognize that actually some of those bits of the history that the patient had given wasn't true. So I think it's the history holds the key to making the diagnosis.
No, absolutely, and so if I guess hallucinations and sleep and gait should just be sort of red flags that we should think about. Brilliant, as always. Thank you very much, Bijou. I'll let you go back to work or back to sleep, whichever.
Back to work. Thanks very much.
Back to work.
See you. And Ashley, see you later.
Okay, on to Natalie. Dr. Elliott is, now I'm going to get the title wrong now, National Lead for Allied Health Professionals in Dementia in Wales, something like that.
That's pretty good. I think you've done better than I could at the moment, Tony.
Okay, well, she's also clinical background is consultant speech language therapist, and we are sort of very lucky to have her and to speak today, because she's actually on maternity leave, and so again, somebody who I'm particularly grateful for agreeing to speak, although my experience of young children, it's quite nice to have an excuse to have an hour's break from them every now and then. So Natalie is going to specifically talk about in a way, the third commonest neurodegenerative disease, Alzheimer's disease being the first, and Lewy body disease is the next, and then frontal temporal dementias being the last. So okay, over to you, Natalie. I was going to ask you going to share your own slides, but you obviously are, so that's good. Thank you very much.
Tara's actually, thank you very much, Tony.
Oh, Tara's
actually in control for me.
Excellent, even better. Good teamwork.
Really helpful. Thank you.
Okay, over to you.
Okay, brilliant. So thank you for the introduction. I'm getting a lot of echoing. I'm not sure whether that's because anyone else. Oh, it's gone now. That's better. That was really helpful. Just to give you a bit of a background to me, as Tony said, I'm here with a hat on as in a national role, leading for the allied health professions across Wales in dementia. But previously I worked in memory assessment services as a speech and language therapist, and one of the things that I was involved in doing as part of my role in that team was helping support the differential diagnosis of some of the dementias, which often included frontotemporal dementias, referrals for diagnosis for primary progressive aphasias in particular. So that's kind of why my previous hat is quite important in this talk. So Tara, if you could go onto the next screen for me. Oh, I should have said, actually, I'm happy for people to get into contact with me. You'll have seen on the first slide my contact details, but bearing in mind I am on maternity leave at the moment until sort of March, April time. So you may have to sort of hold off any burning questions until I'm properly back in work. Thank you. But you can find me on Twitter as well if you want. So I believe you have been following this kind of structure across the faculty, and it's just highlighting on the first slide here. These are the subtypes of dementia that I'll be covering in my talk. So you can see that they fall under both frontotemporal dementia and some subtypes of Alzheimer's disease, which will become a little bit clearer as I progress through the presentation slides. So next one, please. Okay, so this can be a little bit confusing, so I'm going to try and explain it as clearly as I can, but you'll have this as a reference point to help you. As you're looking in the literature, historically there have been some usage of these terms to mean similar things or different things. So just to be clear in terms of what we're talking about today, when we talk about FTD, this is an umbrella term of clinical symptoms. When we talk about frontal temporal lobe degeneration, that's where we're talking about the pathology. And the way that these conditions are broken down, if you've got the frontotemporal dementias, that being the sort of umbrella term of the clinical features, this can be then broken down into the primary progressive aphasias, of which two of those subtypes, there are three. Two of those subtypes are rooted from frontotemporal lobal degeneration. So those are the semantic variant of primary progressive aphasia and the non-fluent variant. And these are also described in the literature more recently as the language-led dementia. So you may hear that terminology as well. And that has been adopted because really it describes the conditions very well. So it's about conditions that where language is the most prominent feature early on. But you'll see there's a third primary progressive aphasia or language-led dementia, and that is the logopenic variant. However, this one is a subtype of Alzheimer's dementia if we're talking about pathology. And then we've also got the behavioural variant of FTD. And again, sometimes it'd be important if you're looking at people's notes and you're seeing FTD to ask the question of which type, because there is historically, sometimes people will say FTD and they're referring specifically to the behavioural variant. So it's really important because they are very different presentations that you explore which subtype the person presents with. So next slide, please. Oh, sorry, I should have added that there are some, there is, if we go back to the slide before, sorry, Tara. There is some overlap with these conditions. So as we know, people don't always fit really neatly into these boxes that we describe. And we do see overlap with some of the motor sort of degenerative conditions, which I've listed there, the main ones, so PSP, CBD, MND. And there is more recent sort of acknowledgement in the literature there may even be other subtypes of FTD, and it's not clear whether those are distinct on their own or whether they're just part of these ones that we already recognise. If we just move on. Thank you. So just to share as well that you know, typically we will be seeing quite differences in terms of when we're looking at neuroimaging of where the degeneration in the brain is occurring for each of these different subtypes. If we go on to the next slide. And you can see the same from this here and how this relates to the different symptoms that we will see then when people present. If we move on now, please. So just to summarise, what I've tried to explain there is that FTD is a behavioural disorder, sometimes used to describe the behavioural variant versus the umbrella term for clinical syndromes, which is associated with frontotemporal lobal disorder and not Alzheimer's pathology. And then we've got semantic dementia, we've got progressive non-fluent aphasia or the language-led dementias, which implies the non-Alzheimer's pathology within PPA classification. And that doesn't, so when we talk about primary progressive aphasia, it doesn't give us any information about pathology. That's where we have to see them sort of broken down. So next slide. Just a little bit of information about some of these conditions. So you'll see that some of them have much greater sort of family history. So it can be quite an important question to ask, particularly behavioural variant. You'll see there much more sort of common amongst, you know, if you've got someone in your family who's had that condition. And then age of onset. You'll see, generally speaking, these conditions are more common in people who are younger. So we tend to see, as you can see, sort of the middle column, the most frequently sort of diagnosed around the sort of 50s to 60s. But you do get people who are presenting later in life. So don't exclude these conditions completely when you're seeing people who are in their 70s, because it is still possible for people to sort of present with them. And also, I think the other thing is that they can be quite difficult to get the diagnosis correct as well. Sometimes people are referred and seen by lots of people, or maybe don't come forward and present as early as what the symptoms might have started. So sometimes people maybe not come into clinic and getting their diagnosis later because of that as well. So next slide, please. Okay, so I'm going to go through each of the variants and just talk about some of the symptoms, the clinical picture that you may see. So semantic variant or semantic dementia is a disorder of conceptual knowledge. So the main features that you would see are impaired naming. So that's also known as anomia. Where people would use the wrong word and often with a semantic similar word. So, for example, somebody might call a mouse a cat. One thing that is quite striking in this condition as well often is that they will have impaired word comprehension. So you can ask them from a series of pictures to identify which one is a dog, and they will really struggle to recognize that, and they may even struggle to differentiate, you know, which one is an animal from non-animate objects as well. However, they often will have very good speech fluency, grammar and syntax, and they can use some of these words that on these comprehension tests or naming tests that they are unable to score well on, but they can still use them in conversation when it's led by themselves. They also will often have some non-verbal semantic impairment. So this can present as difficulty recognizing faces or objects, what to do with them, not always recognizing non-verbal sounds, smells, tastes, trouble with tactile cues as well. People may not have all of these features, but they're good to be sort of asking questions around when you're taking the history. Something that can be quite confusing when you're taking a history is that often people will be described as not remembering things. So this can lead to people being misdiagnosed with Alzheimer's dementia. So it's really important to ask a few questions to sort of dig into this and get some examples of the kinds of things that people aren't remembering, because sometimes with someone who has got semantic dementia, when we sort of pick this apart, it's actually that they aren't, that they're having difficulty with words. So remembering how the word associates to an object or to a person, or recognizing the face of a person. It's quite different to the sort of type of memory, the episodic memory difficulties that we see in someone who does have Alzheimer's dementia. And they do tend to have very good day-to-day memory. So if you asked, you know, what are they like at getting to places on time, finding their way around places that they know well, being able to recall sort of recent events, things like that, usually in the early stages, people are still very good at those things. People can become quite sort of rigid as well around certain things, around their routine. For example, one of the features is that they might become quite set around time, so and get quite agitated or find it quite difficult to not stick to those times, like, you know, meal times have to be at a certain time of day. And also developing quite sort of narrowed interests and perhaps preoccupations, or even sort of obsessive tendencies, is also a feature that we see presenting in semantic variant. Tara, if we can move to the next slide, please. Thank you. So non-fluent variant primary progressive aphasia. This is a type of motor speech impairment. And it's where the person will present with quite effortful production of speech. And sometimes this can be described like an apraxia of speech. So rather than someone who has semantic dementia who can be very fluent but not have a lot of sort of content in what they're saying, a person with non-fluent variant is agrammatic, so it's very effortful. It might be quite stop and starty. And they often have sound errors in their production of words, so they're not quite hitting the correct sound patterns when they're trying to say a word. And at the beginning, in the early stages, this can be really subtle. So it may just be a slight change in the sounds. So it may not be, super effortful initially, but just that they're sort of mispronouncing things. And also another thing is that they will have a word retrieval impairment. So they know what they want to say, but they're having difficulty retrieving the correct word. Generally, early on in this condition, comprehension is still very good. Particularly of words and single words. It may be that they have more difficulty with longer pieces of information. So maybe at paragraph level in the early stages, we might see some impairment, but generally word comprehension is very good until sort of more advanced stages. You might see some cases of also sort of orofacial apraxia, where there's changes to the control of the muscles in the face as well. So you may see some, if you're asking people to do certain facial movements, some difficulties with effortful ability to kind of copy and implement those. You can also see some changes to limb rigidity and apraxia. Not always, but again, that's just one of the ways that you can see some of this overlap with some of the other movement disorders. And again, as well, we might see some behavioural changes consistent with some frontal lobe involvement. Okay, next slide. So this is the third primary progressive aphasia, and this is the one that actually is the pathology is an atypical type of Alzheimer's disease. So it's it's got sort of different things that you'd be looking for, and that actually you'd be looking at them having more of those kind of cognitive changes that you might typically see in someone who has got Alzheimer's. But the primary here symptom initially is changes to language. So some of those things to look out for are word finding difficulties and pauses in speech. So again, they're having difficulty retrieving the words. Know what they want to say often, but having difficulty finding those words. And if you look at naming tests, they will come out as impaired. And again, another term for that is anomia. So here as well, they will have difficulty repeating words. So they've got poor repetition, particularly at sentence level, which usually relates to memory. So you'll tend to see a length effect. So they can only sort of hold on to some of the sentence to be able to repeat it back to you. You might get some sound errors, like what we saw in the non-fluent aphasia, but early on, this is less prominent a feature. You'll also get impaired comprehension of sentences and paragraphs, and that's with intact single word comprehension. And again, this is more a sign of difficulties then with sort of memory and holding on to that information and processing it. So as I said, the language difficulties go alongside other cognitive changes. So things like working memory impairment, dyscalculia as well, sometimes limb apraxia, and episodic memory impairment is usually present. It can be difficult with, especially sort of early on, to say whether somebody is fluent or non-fluent, because they can present with features of both, depending on the sort of environment and situation. Next one, please, Tara. So this is quite a useful flow to work through if you're seeing somebody and trying to sort of think through which subtype do they have. So there's a reference down at the bottom, and I would say that this is just a really good one. I used to find it quite helpful to have just a copy of this printed out and kept in my assessment pack. If I was working with someone, I could just kind of work through the sort of yes, no, and think about what things I needed to check out. So we move on to the next slide. Okay. So behavioural variant FTD now. So as it says on the tin, this is often what we would see as changes to behaviour in this variant. So typically we'd see things like disinhibition, so socially inappropriate behaviour. Apathy is a big one, actually, that sometimes doesn't come forward as quickly, in terms of people may have been having some of those symptoms for quite some time before they seek help, and it's often the family and partners who will pick up on some of these things. So just starting, seeming to lack any inertia, self-neglect and unconcern. People with behavioural variant often, a bit like Bijou was saying in his talk, aren't very aware of these changes themselves. So having that collateral history is really, really important. A big one here as well is changes in emotion. So family will often sort of find this one really difficult, that a person can just lack any sympathy or empathy, not feel any embarrassment about things, and just not respond really in a way that you might expect. I remember a case where one family member, when they received the diagnosis and understood some of these symptoms, was just so relieved, because there'd been in the family a recent loss of someone who'd been very close to the family, and this individual just had sort of no real reaction to that at all, and hadn't been able to sort of sympathise or empathise with the way that the daughter was feeling in terms of loss, which is really out of character. We also see repetitive behaviours, so things like developing sort of rituals and routines, pacing, hoarding. I remember visiting one person who his wife sort of retrospectively said one of the early signs was that her husband had become sort of very, very specific about where all the ornaments had to sit, and if she'd been doing sort of the housework, she sort of moved them slightly out of a bit further back, say on the shelf or something, that he'd go round and correct them all. There was a set way that everything had to be placed. Dietary changes are really common as well. There's problems with regulation, so people might overeat. They might develop really strong preference for sweet foods and become quite sort of faddy about the types of foods that they'll eat. You might see them sort of putting, not being able to sort of control how much to put in the mouth in one go. And again, you may see some of these sort of behavior patterns as well coming out in how the person chooses to eat. So again, another example of somebody that I saw was that the wife was having to cut the food up very specifically, so that if she gave a sandwich, it had to be very much cut in half equally. That was really important, that one piece wasn't bigger than the other, and the person would, before they ate the food, they'd want to sort of line up, say if they were eating chips, line up in size order before they started to eat them. So you know, quite unusual behaviours that that person would not have done any of those things previously. Also, response to stimuli might be altered, so they can become hyperreactive or hyporeactive, so underreactive to things. And you can see some psychotic features, so some delusional beliefs and hallucinations sometimes. In terms of cognitive problems, difficulty with planning and forethought, organisation and sequencing is another area, and abstraction, attention and monitoring, being able to make decisions and make judgments. People can, with this variant, be quite sort of socially vulnerable. They can have difficulty with mental flexibility and perseveration of thinking and behaviours. We also see a reduction in verbal fluency on cognitive tests. And really big here in this variant is lack of insight, and that can be one of the things that's really hard for family. So next slide, please. Okay. So I'm not going to go through all of this in great detail because I'm just aware of time just flying, but as a speech and language therapist, I couldn't not just mention that although behavioural variant FTD isn't seen as one of the language-led dementias, there's actually some very specific changes to communication that you would see in this subtype. And a speech and language therapist can be quite helpful then in helping with the diagnosis and identifying some of these sort of key features here that we might see. If we move on, Tara, please. Thank you. So what I really wanted to do is just to talk through a case that I worked with, which sort of puts some of that theory into sort of reality, really. And I want you to sort of listen to some of the history and see if you have any ideas before I give you the diagnosis, what this person might have been diagnosed with. So this was a lady who was, at the time of me meeting her, was 70. But she'd first gone to her GP when she was 66, and actually talking to her daughter felt that some of the symptoms were there even before that. They gone to the GP. The family were concerned that she was experiencing carer stress and processing family bereavement. And they were really keen for her to have some psychiatric and psychological assessment. And it was the family that were concerned mainly rather than the lady herself. The history from the family was that she had inability to remember words. Usually the names of things, when that was sort of asked a bit more about that. And she had limited ability to understand what was said to her. So the family had actually asked her GP to refer for a hearing test because they thought she was having problems with her hearing. But actually her hearing was fine. Otherwise, she was functioning really well. She was really well organised. She was able to still, at this point, keep on top of all of her usual jobs around the house. She was doing the shopping. She was brilliant at remembering family birthdays, and you know, people were relying on her to be the reminder of those sorts of things. She loved gardening. And she had a really strong appreciation of number. So she really became quite obsessive almost with number puzzles. Her personal hygiene was really important to her, and all of her sort of the way she presented herself was absolutely fine. She lived by a routine, and she became quite sort of set in this, and family would say, would share that it would be quite difficult sometimes to try and do something out of the normal routine. So for example, she wanted to eat at the same time every day. She became quite fixated on certain things. So, for example, she would refuse to visit one of the hospitals in the area that we were seeing her in. And another thing that had always been important to her was walking and exercise, but it became really important and quite sort of something that she couldn't miss, and almost overdoing it really in terms of these things. When I met her, at the point that I saw her, she wasn't able to participate at all in memory clinic in a standard cognitive assessment. So it been attempted to do an ACE and a MOCA with her, but she just wasn't able to do that. And she was referred to me as a speech and language therapist for an opinion as to whether it was that she had, really severe general cognitive impairment, or whether she was having difficulty completing the assessment due to some language impairment. So next slide, please. So she'd been referred by a member of the medical team for a SPECT scan. And this is the report. So there was asymmetry particularly around hypoperfusion on the left frontoparietal cortex, and it also involved the temporal cortex. But otherwise it appeared normal. There were some signs of generalized atrophy, but the pattern was described as abnormally is non-specific and would include vascular causes, but not typical of of Alzheimer's. So if we move on to the next slide, please, Tara. So I saw her for a speech and language therapy assessment, and this is what I found. It was actually quite difficult to also complete a thorough language assessment with some of the standard tests. She has severe semantic impairment of both spoken and written word to picture matching. So if I gave her a word and asked her to match it from either the spoken word or the written word to a selection of pictures, we only tried a few because she just could not do it at all. So her response to that may, for an example here, can you point to the dog? What's the dog? And then she would point to all of the pictures and ask me, is that it? Is that it? But actually her family had brought along a lovely photo album to show me and to support conversation. We looked at that and she was able to use the word dog very appropriately in conversation when we were interacting with some family photos. We also looked at her picture naming, and she, again, we only did a small number of the test items, and she got 2 out of 10. She was able to read aloud, though, written words, but she, no sound errors at all in her speech, but she just could not attach the meaning to those words. So we move on to the next slide, please, Tara. So when she was able to direct the conversation, she was very fluent, but she did have reduced content words. So you had to sort of really concentrate to follow what she was trying to say, but she was really trying to communicate, and I remember the first time I met her, she wanted to show me that she was physically very well. So she got up and said, I can do this. She couldn't give me the word for what she was trying to say. So she got up and ran around the table to show me that, physically she was still very active and very capable. She didn't have, as I said, any speech errors. She was unable to participate, interestingly. See, if you let her lead the conversation, she was fine. If you asked her a question and tried to sort of lead the conversation in a direction you wanted, then she could not follow. She'd often shift topics in conversation, and it could sometimes be quite difficult to sort of follow where her train of thought was going. If we move on to the next slide, Tara. So she did have some insight actually when I first met her. She said to me, I don't recognise people, I don't know who they are, it's a shame. And, you know, she would say to me during the test, what is it? I don't know that word. And she also, interestingly, whilst the family weren't using the word dementia at this point, she was saying, I have dementia. You know, she had sort of some empathy there as well. She was saying, oh, it's sad. She also talked, you know, negatively about it. It's time for me to go now. And so the family had been quite concerned about her mood. And if you remember from the history at the beginning, they were concerned. She'd been a carer for both of her parents, and they'd recently passed away, and they were sort of seeing some of this as maybe sort of grief and bereavement. She didn't have any evidence of episodic memory impairment. Behaviours wise, just to summarise, we could see from the history she had quite routine-led obsessive tendencies and some repetitive behaviours. So next slide, please, Tara. So before I move on, does anybody want to say what you think the diagnosis might have been for this lady?
Semantic dementia.
Yes, who was that?
Lisa.
Hi, Lisa. Yeah, great. Have you got experience of working with anyone with semantic dementia, Lisa?
No, I've never come across it.
Ah, okay, brilliant. So you listened really well to the description, and yeah, brilliant. So yeah, this lady did have semantic dementia. So Tara, if you just bring up, yeah, we ended up having a joint session with myself as a speech and language therapist and the medical team who'd seen her in clinic and referred her to me to discuss her presentation and to make a diagnosis jointly with the family of semantic dementia. And this was at least 3 years after they'd raised initial concerns with the GP. So we move on, please, Tara. So here in these conditions, you know, you may ask why, maybe thinking, why is differential diagnosis important? Hopefully I've been able to describe so that you can see the quite different clinical trajectories that these subtypes have. And it's really, really helpful for family to just understand, get that information and to prepare for the future. This article here that you can see on the right that's in your reference list is one that was done by the daughter of a lady that was in my care, and she talks about their experience of semantic dementia as a family, and you know, some of the tips that she's learnt from having a mum who lived with the condition, in terms of what she'd share with other people about how to think about the future and try and plan as a family. And also, as you saw in one of the earlier slides, there is occasionally, depending on the variant, some genetic risk. So for some families, it may be something that you would want to talk about, and some people have occasionally been referring them on for genetic counselling if they're interested in exploring that further. The next slide, please. So as a speech and language therapist and a national lead for HPs in dementia, I also just wanted to make sure that you're aware this is a really recent piece of work that's been launched back in September, October of this year. This is the Allied Health Professionals Dementia Framework for Wales. And linked to my talk here really is just to make you aware of the important roles that AHPs can have in differential diagnosis. I'm not sure if we have any AHPs in this cohort. But I'd encourage you to sort of think, if you're seeing people with these rarer dementias, about members of your team that might be useful, have useful expertise to call upon, both to help with the diagnosis, but also for that post-diagnostic support. And particularly with these sort of language-led dementias, ideally we do need to be seeing speech and language therapists across Wales getting involved in helping get the diagnoses correct, and helping with post-diagnostic support as well. So next slide. And just to help you out, if you haven't got time to read the whole document, there's just on pages 49 and 50 a couple of key points that link to my presentation here today. One of the priorities that we're calling for is to raise awareness of the role of AHPs working in dementia care and supporting people living with dementia and their families. And we really want to see an increase in access to these professional groups in memory assessment, as we see in the Dementia Action Plan, and making sure that people are getting a timely and accurate diagnosis and the right post-diagnostic rehabilitation support as well. And next slide. I think that might be the end, actually. Yes, so that's Tony's talk. I was thinking, I don't think I've got 46 slides. So thank you.
That's great. Thanks very much, Natalie. Are there any questions or points people want to raise with Natalie? Or I'm wondering, has anybody has anybody seen a patient with any form of frontal temporal dementia? Because it's a bit of a cliche, but once you've seen one person with dementia, you've seen one person with dementia is often trotted out. That's most certainly true of frontal temporal dementia. One person with frontal temporal dementia can be very different from another. Has anybody come across any patients? If not, I can tell you you've missed them, because you're about 2-3% of people with dementia have frontotemporal dementia, and in the under 65s, frontotemporal dementia is more common than Alzheimer's disease. It's going to make up perhaps about 40% of people with younger onset dementia, but it often is overlooked and misdiagnosed. Nobody's edified. Okay, well, the message is, if genuinely you can't ever recall seeing anybody with frontotemporal dementia, then there's certainly a lot of, well, not a lot, but there are a couple of diagnoses either being missed or miscommunicated, and in fact it's one of those things that does make a lot of difference, because when people are talking about supporting people with dementia and talking about dementia, it's very, very memory centric. It's very Alzheimerized, and people with frontal dementia, temporal dementia, whose main problems are with language or with behaviour, just can't relate to that, and their families can't relate to it. And I can think of people with frontotemporal dementia who perhaps were referred to the Alzheimer's Society and went to Alzheimer's Society meetings and actually came away after their one visit saying, oh, well, no, that's nothing to do with us. And they start querying the diagnosis of, well, do they have any form of dementia? So actually getting the diagnosis right is important. Lisa.
I've seen, I think, two that stick out in assessments that were all about sort of language, and sitting and listening to that, it's fitted in those boxes. But because we go on to have the consultants diagnose, we don't always have the feedback of what the actual diagnosis was. So I couldn't tell you if they went on to have that diagnosis, but listening to that presentation definitely fitted in a few of the boxes there.
It strikes me that then, just as a generalization, that if we would earlier we were talking about initiatives or developments in different areas. In fact, that's a good example of if you're doing a lot of the groundwork and identifying all the problems and presenting them to somebody else who is then labeling the person and communicating it, it's too much like a conveyor belt of and all sort of compartmentalized. And certainly the model that I'd certainly support, and I think Michaela and Natalie would very much support, would be much more a genuine sort of multidisciplinary, interdisciplinary model, where that just doesn't happen because everybody is communicating clearly with each other. Okay, if there aren't any,
can I just add to that, Tony? In the case where I presented with the lady with semantic dementia, one of the things I think was really important in helping the family and her sort of accept and understand the diagnosis was that we'd taken that joint approach in discussing and giving the diagnosis jointly. So I'd done a lot of those assessments, but the medical team were also present, who'd seen her and referred her to me, and we discussed the diagnosis and made a plan for the follow-up.
It's also helpful, I think, because in a way, if there are two professionals sharing discussing diagnosis, to some extent you can bounce off each other. So if in this particular case, if it's highlighted the problems are to do with your bereavement or grief or whatever, well, then perhaps Natalie can highlight, well, yes, but that wouldn't explain the specific problems about being able to name things. And the medic, in a way, does have the advantage that they can explain why they aren't other conditions, because one advantage that a medic has is hopefully they have a sort of broad view across the whole of medicine, not just their own particular specialty. So I think actually, again, sort of frontotemporal dementias are a real example of where multidisciplinary working can be helpful. And going back to say Biju's previous presentation, where people present with gait disorders and the Parkinsonism, say in Lewy body disorders, you're having a discussion with the medic and perhaps a physiotherapist or OT can be especially helpful. I know there was, I think in earlier times, there was a discussion from some areas about how keen they would be to have a speech and language therapist in their particular region. So now you've seen Natalie, and you can now, you've got the reference manual that she's just put up, and you can make your case armed with the document from Welsh Government and Natalie when she's back genuinely working, then I'm sure she'll be very, very supportive. Brilliant. Thank you, Natalie. You can now go and back to childcare, and we look forward to seeing you next year, having a break from childcare and back to work again. Great.
Thank you. I'm going to stick around and listen to you, actually, Tony, if that's all right.
Merry Christmas, Natalie, and Christmas with your first baby. Baby's first Christmas.
In fact, Natalie is so keen that she's to keep her mind active. I think she's going to stay for the rest of the afternoon.
Good.
Yeah,
I can
a bit longer.
I can see that Shami, Dr. Bhattacharya has just joined us. That's terrific. Can I suggest, if it's okay with Shami, could we have a break for 5 minutes, which would mean by my clock we'd be coming back at where are we? 3 minutes to 3 o'clock, and then we can make a break, and it will mean everybody can rush to the loo or do whatever they have to do.
Of course, Tony, lovely to see you.
Excellent, good. Could everybody put their hand up now then, so that we know when you're back? So if everybody just raises their hand, and then as soon as you're back, can you lower it, and then we'll know that we can start. Great. Okay, 3 minutes to 3, we're back here.